So next we'll see about the inflammatory bowel disease. So we have two types of inflammatory bowel disease, which is Crohn's disease and ulcerative colitis. So Crohn's disease is going to be associated with HLA-DR1. So this is a very important topic, and lots of MCQs are there for in IBD. So Crohn's disease is associated with HLA-DR1, while ulcerative colitis is associated with HLA-DR2. And Crohn's disease is again associated with CD4, both are CD4 related responses only, autoimmune response. But here it is going to be TH1 and TH17 related response, while in ulcerative colitis it is going to be TH2 mediated response. So interleukin 23 receptor polymorphisms are going to be protective for Crohn's disease, while interleukin 10 gene polymorphisms are associated with ulcerative colitis. So the most common site involved in the Crohn's disease will be terminal ileum. So the entire GIT can be involved in Crohn's disease starting from the mouth to anus, but the most common site will be the terminal ileum. However, in ulcerative colitis, the disease will start in the rectum. So there will always be rectal involvement, and from there it can proceed proximally and involve the entire colon, also intestine. It can also involve the small intestine, which is called as backwash ileitis. So both of the IBDs are going to present with the same clinical features. That is, the patient is going to have intermittent diarrhea and then associated with abdominal pain, and usually the diarrhea is going to be nocturnal. So intermittent nocturnal diarrhea along with abdominal pain and malabsorption, so steatorrhea and all those symptoms will be there. As such, ulcerative colitis is going to cause ulcer, right? So there is going to be lots of hemorrhage associated with it. So there will be production of blood and mucus. So dysentery kind of image will be there on, presentation will be there on ulcerative colitis. So both, again, it's not restricted. Both of these diseases are not just restricted to the intestine. They can have other extra-intestinal manifestations as well. So in Crohn's disease, we are going both the diseases we are going to have migratory polyarthritis. Multiple migratory polyarthritis is going to be there. Along with that, joint diseases. So ankylosing spondylitis, sacroiliitis, then skin diseases like erythema nodosum, uveitis, cholangitis is going to be there in both the conditions. But in ulcerative colitis, we have a special association with primary sclerosing cholangitis. So PSC, so it is a bile duct disease. So that is also an autoimmune disease. So primary sclerosing cholangitis is going to be associated with ulcerative colitis, and PSC as such has an increased risk of cholangiocarcinoma. Okay, so remember this. And both Crohn's disease and ulcerative colitis are pre-neoplastic, and they can have a increased risk of converting into intestinal colonic cancer, but intestinal cancer. But still, the risk is more associated with the ulcerative colitis. So maximum amount of risk will be there in ulcerative colitis as compared with that of a Crohn's disease. And you can see ASCA antibodies on screen while screening for Crohn's disease. You can test for ASCA antibodies, which is present in the Crohn's. So ASCA stands for anti-Saccharomyces cerevisiae antibody, while P-ANCA, which is the perinuclear ANCA antibodies, will be present on the ulcerative colitis. So some gross features are also very important in distinguishing between these two diseases. So in Crohn's disease, we are going to have multiple skip lesions, meaning it's not the entire bowel which is being involved continuously. So some part of the bowel will be involved, then there will be normal part, then again involved bowel part will be there. So this kind of skip lesions is characteristic of a Crohn's disease. And in Crohn's disease, you can have associated strictures, fistula and fissures. So stricture, fistula and fissures are not going to be present in ulcerative colitis. And while if it is a ulcerative colitis, in ulcerative colitis, the entire lesion is going to be continuous. So if the disease has started from the rectum, it will then proceed on to the sigmoid colon, descending colon, then it will go on to the transverse colon, ascending colon. So there will be a continuous kind of an involvement here. So that will lead to a pancolitis and a continuous lesion. And I also mentioned it can even reach up to the ileum, causing backwash ileitis. In Crohn's disease, the classical appearance of the mucosa is called as a cobblestone appearance, meaning it is going to appear as if there is pebbles stuck on the mucosa like this. So why is it so? This is having some ulcers, right? So the ulcer part is the one which is having this area, while the normal mucosa which is appearing like this is the one which appears like as if there is a dome shaped thing. So the part which is the flat one is actually the ulcer, which should have actually been at the level of the dome of the mucosa. So it gives a cobblestone or a pavement appearance. While pseudopolyps are common in ulcerative colitis. Same reason again. Here also, if you see, these polyps are all the normal mucosa only, but the rest of the mucosa is ulcerated. So the normal mucosa appears as if it is being protruding. So it forms the gives appearance of pseudo polyps. These are actually not polyps. That is why it's given the name pseudo. So ulcerative colitis is also associated with toxic megacolon. Then in Crohn's disease, we are going to have creeping mesenteric fat. So the mesentery, rather than being restricted till here, it is going to go on to the intestine and overlap the intestinal part. So it is called as creeping mesenteric fat. And on radiology, if you see Crohn's disease, since it has these skip lesions, it is going to appear like a string. So here this part is normal, here it is thinned out. Here again it is thinned out, right? So this kind of appearance is there, which is called as the string sign of Cantor. String sign of Cantor is seen in Crohn's disease. While on radiology of ulcerative colitis, there is going to be loss of the hostration. So normal colon will appear like this, right? It will have the hostrations. While in ulcerative colitis, this hostra are all lost and it is just going to appear like a smooth pipe. So it is called as lead pipe deformity, which is seen in ulcerative colitis. Microscopically also, we are going to have differences. So in Crohn's disease, the classical feature will be, it was one of the examples of granulomatous inflammation, right? So it is a non-caseating granuloma, right? So we can see non-caseating granulomas, and the involvement here is transmural. So transmural in the sense there is going to be all the layers are involved. The entire length of the wall thickness of the bowel is being involved, starting from the mucosa to serosa. So inflammation is there in the entire bowel wall. So this transmural involvement is classical for Crohn's disease along with non-caseating granuloma. So this is a granuloma here. You don't see any necrosis over here. It is just these epithelioid cells and giant cells and lymphocytes surrounding it. Okay. While in ulcerative colitis, it is going to be a superficial lesion. So it is not transmural. The ulcers are going to be quite superficial. So involving the mucosa only. So the ulcers are going to be there. Along with that, there is going to be lots of crypt abscess and cryptitis. Okay. So neutrophils are going to fill up the crypts which are called as crypt abscess. And there are no granulomas, fissures, strictures, or any fistula seen in the ulcerative colitis. So I already mentioned in Crohn's disease, you can have any of the GIT which is being involved, starting from the mouth to anus, right? So these fistulas, fissures can be seen in the anus commonly, while aphthous ulcers, which are very common in the mouth. So the disease starts with the aphthous ulcers. It is the earliest sign in the earliest lesions in the Crohn's disease, and these ulcers will have a serpentine appearance like a snake. So these are called as serpentine ulcers. So in Crohn's disease, what were all important? So firstly, the HLA association was different. HLA-DR1, HLA-DR2, Th1 and 17 response, Th2 response. Then we had this involvement of terminal ileum here. Then entire GIT can be involved most commonly. And here the rectum was most commonly involved, from where proximally it can extend, involving the pancolitis. Then we had various extra intestinal manifestations, in which primary sclerosing cholangitis was seen in ulcerative colitis, which can have an increased risk of cholangiocarcinoma. As such, there is going to be increased risk of adenocarcinoma for both the conditions, but more risks is associated with ulcerative colitis. Then we had the gross appearance, in which skip lesions are present in Crohn's disease, along with cobblestone appearance, formation of strictures, fistula and fissures. And then there will be transmural involvement in the Crohn's disease. While in ulcerative colitis, we had continuous lesion involvement forming a lead pipe kind of a deformity. Here there are no granulomas or stricture or fissure formation. And here we'll have pseudopolyps and toxic megacolon.